Hello and welcome back. I'm Eric Sunset, your host of the Doc Buddy Journal. Here at Doc Buddy, we deliver healthcare solutions that take the pain and cost out of broken workflows like OpNote, which gives ASCs the power of instantly generated operative reports approved from the point of care. You can learn more about OpNote and all of our solutions at docbuddy.com. And today we're joined by a guest that really needs no introduction. We're joined by John Goehle. John is one of the nation's leading ASC experts. He's written 8 books on the industry, including The Survey Guide for ASCs, a guide to the CMS conditions for coverage, and interpretive guidelines for ambulatory surgery centers. He is also the host of the ASC podcast with John Goehle. John, thanks so much for joining us.
Thank you so much. Yeah, I always when people introduce the titles of my book, I always realize I really have to come up with shorter titles. It just takes too long to bring those up. But thank you so much for inviting me to talk with you today.
Oh, our pleasure to have you here. Thanks for making the time. And related to the book topics, or the book titles rather, great for SEO. I say go longer if you can.
True enough.
Hopefully that was a fair shake on the introduction, but what else should listeners know about you before we dive into the meat and potatoes of our show today?
Yeah, I was kind of shocked. I just came back from I'm a Triple HC surveyor, and this last weekend was our biannual get-together. We get together every 2 years, and this is the first time that all 250-plus surveyors were together at the same time. Usually they split us up. It was a wonderful weekend, and just a lot of great learning, a lot of great time spent with my colleagues. And I realized I've been a surveyor for about 20 years, and I've been in the industry for 35 years. So now I'm starting to feel really old here. And the people that I'm running into are so much younger than I am. There's not that many of us that can count 35 years in this industry.
Yeah, that's something. And I don't know if you feel the same way, but we've post COVID and even kind of running up to COVID. Oh, let's do it remote. We can all do it on Zoom, and it's the same. It's really not. There's nothing like the energy of being together.
And that's the sessions were not nearly as important. They were important, but not nearly as important as that interaction, the stories that we tell. And of course, it's very important as surveyors that we learn from each other. And a lot of that learning occurred in between sessions and at lunch and at dinner and our cocktail parties. By the way, you get a bunch of surveyors together. There's usually some alcohol involved. So, and then you really get some good stories. So.
Not hard to believe. And Doc Buddy is actually coming off of our team retreat in Denver just last weekend. And it's a group that you see on Zoom week after week. You're talking to your coworkers on Slack or Slack huddles or whatever. And it's great. You love the folks you work with, but there's just nothing like being together. It's irreplaceable.
Well, and I own a company called Ambulatory Healthcare Strategies too, as well as the podcast and ASC Central. And we get together twice a year for our retreats, and we try to encourage everybody to come together. We have about 27 employees, between those 3 entities, and we cannot get everybody together. I mean, it's impossible to coordinate the schedules. We have employees in, I think, 6 different states. So first of all, the sheer cost would be enormous. But nonetheless, that hybrid model we're starting to get used to, and I think that's an interesting point I should make too, is how rewarding it can be for your organization, ambulatory surgery centers out there, to get your employees away from the workplace, or at least away from work, to spend some time in a retreat, talking about what's going on, developing long-range plans, which are required, for accreditation purposes. But make sure everybody's on the same, path forward in your organization. It's also a good time, of course, to do the mandatory annual education and any other education that you might need. But and if you can sneak those doctors in, or at least a few of the doctors in, that makes it even better to hear directly from them what they expect of that organization.
That's kind of a nice lead in, John. One of the things we wanted to talk about today was overcoming staffing challenges in the ASC. And it's not unique to the ASC. You see it across all industry. Medical seems to be pretty hard hit, though, whether we're talking about the practice or the surgery center or beyond. We've had guests of the show come on who are leaders in the space, folks like Todd Currier up there in Bend, Oregon, where culture is so important to the center that he runs. And that helps him overcome some of the staffing challenges. And those being both being able to make hires and being able to retain staff. From where you sit, how does culture play a role in, maintaining headcount?
Well, that's a very good question because especially right now with our challenges of finding staff, and it's not just nurses anymore. It used to be, nursing was our biggest challenge, but I mean, even receptionists. If that we're fighting a lot of lower end, or, lower income type positions out there that are creeping up very quickly, which means that our costs are getting more and more expensive, and and of course our costs are going up faster than the inflation rate, and we know that. Well, for example, the 2025 payment rule update that CMS just put out in early July proposed an increase of 2.6%, and yet the inflation rate is 3.0% as of the end of June. But that's irrelevant when you consider what we're paying, what we're finding, demands for, higher, cost, for higher salaries for our staffing at all levels right now. Which means, getting to your point, developing a culture. We can't always compete with, with other organizations out there. So we have to develop a culture that makes people want to come, work with us. And it really gets down to, I want people coming to us not because we pay a higher salary, but because they're really passionate about what we're doing in the industry and the environment that they work in. And I think many surgery centers, I see it every day. Many surgery centers have been able to develop a real culture there of quality, a culture that brings people together in a truly team oriented situation, and that way, they might not be able to pay the most, but people don't want to leave their family, right? We don't want to give up on our families, and if you truly have a family in your organization, that keeps people on board. And another part of culture is making sure that people really feel they have a voice in your organization, that they have the opportunity to speak up when they think something has to change, that they're part of the quality improvement process. Quality improvement is what it's all about in ASCs. It's one of those passions that I have. Anybody hears me speak about quality improvement knows that I start waving my hands and making all kinds of gestures because it's just something I get so excited about. And because I've seen how it can really improve everybody's attitude about their workday, but on the flip side, if it's not there, if they don't feel like they're engaged, if they don't feel like they're part of that team, if they don't feel like they're being heard, then the flip happens, and they're looking for another job where that they'd have that satisfaction.
Well, you're speaking to all the markers of burnout that you see. Pick your source for the study or for the survey. Having autonomy within your role, that's huge. Feeling like you're important to the overall mechanism, the overall organization, and not a cog in the machine. Having agency in your role, that's huge. And burnout's a hot topic in healthcare, whether we're talking about providers, surgeons, nurses, or the front desk staff. And in this climate of being unable to make a hire, no matter how much you're willing to pay or not pay, or how good your culture is versus how lacking your culture may be, you got to do everything you can. Otherwise, you're shorthanding yourself.
Well, and it's not just our employees too. Of course, we're probably speaking to the people that manage those employees, and your jobs are extremely valuable. And finding you is not always easy. We at any given time, I think we have 87 centers, and I think at any given time we probably have 5 to 7, probably even more vacancies or interim positions that need to be filled at some point. And we're hiring younger and younger people. With a lot less experience than our seasoned professionals out there, and that requires a lot of training. That's what that's how we started our pretty famous boot camps out there, our administrators and director of nursing and business office managers boot camps, because we realized there was this huge gap in knowledge and understanding about what it takes to be an administrator, director of nursing in these positions, and for the doctors that are listening, I hope many of you are listening. You got to keep them happy, and the same thing I said about your staff goes for them too. They need to feel like they have the authority to be able to make change. They have the resources to be able to do it, and they have your support. The owner support, the governing body support.
We definitely need to get to this physician engagement aspect
Yeah.
at the surgery center, but there's kind of an interesting dynamic, and it happens all across business, but there's sort of a playbook where you lose an administrator at a surgery center for whatever reason. Oftentimes you're looking to backfill that position by promoting maybe your director of nursing,
Right.
somebody else in the facility, a known quantity to you, and they're great at what they do. They're great as the director of nursing or whatever their title may be, and they find themselves thrust into this new administrative role. There's regulatory blind spots, there's compliance blind spots, there's emergency preparedness blind spots. What do you do to fix that?
That's a great question. Interesting story. I've been teaching nurses since the '90s. I taught in a master's program here in Rochester. I live outside of Rochester, New York, and one of our major colleges here had a program to take registered nurses, BSN, up to master's degree. And I taught in that program. I was teaching them two things: finance and accounting, which you you know you don't get any of that in college, in your RN program, your BSN program. And I also taught them, if you think about the '90s, I also taught them about how to work a computer. Half my class was just telling them where the on button was, and then and helping them to understand that a virus couldn't be caught by the floppy disk that they inserted into the computer. True story, by the way. But we've come a long way since then, but the problem still remains that the nursing education that they receive doesn't include finance, doesn't include a lot of human resource management, certainly doesn't include the regulatory aspects, and all of those things that are important, even to become a director of nursing, let alone to move into administration. I would argue, to your point, that you've got to have some good financial background even to be a director of nursing now. When I teach our administrators, I say, you only control half of the budget. If that, you need to get together with your director of nursing and make sure that, because that individual is going to be controlling your nurse staffing, clinical staffing, and probably controlling your supplies cost also. And which is one of the reasons that I think DONs often become administrators, is because they have that background. But there is so much that has to be done, and the problem is, realistically now, with everything that is going on, they don't have the time often to do that. They need other resources. They need to be able to, work with other individuals. And of course, they're not necessarily going to get the support from the owners. Maybe financially they don't have the financial resources to have both an administrator and a director of nursing, which means that, the DON/administrator is going to have to learn all of these positions and then have some real good support systems, hire additional staff or identify individuals in the organization that can take on some more of those responsibilities. For example, if you're a DON/administrator, maybe you're going to have one of your stronger nurses be your infection control nurse. Maybe somebody else is going to be in charge of the quality improvement program. Or maybe you don't even have those resources and you end up having to hire a company like ours, to come in and provide that back support. And at the very least, making sure that you're on top of the news. I'm very passionate about something else, and that is supporting the state associations out there. I know you and I were talking about that before we came on. And, your state association can provide you an incredible wealth of information, not always on site, not always on their website, but definitely at their conferences. And of course, again, just like I was talking about with AAAC last weekend, being able to meet with people. I mean, the conferences are important, the content's important, but getting together with other like-minded people, your colleagues out there, knowing somebody to call, when you run up against something you haven't run up against, before, is so valuable. And if you can afford it, become a member of the National Association, the ASC Association, which gives you even more information. But without those resources, our administrators, our directors of nursing are going to have a real challenge. And in particular, nursing, I feel for them. I'm surrounded by nurses all the time. I live with two of them here, and it is a huge challenge. And there's their training is different than mine. I was trained as an accountant. They're much more into taking care of the patient, recognizing the importance of that. Admittedly, mine is a lot of finance background, and I've learned over the years, to understand what's going on in that. In their minds, but having them pick up finance is not a natural. It's not something that they're very comfortable with. I do joke with them, though. I got to tell you, when they come back to me and tell me that they can't handle the math that's involved in finance, I said, then don't give me an injection because you're going to mess up, that the amount that you're going to give me. I think their math is probably more complicated than much of my math in the finance area.
That's too funny. And yeah, we're going to go off script a little bit here. There's sort of in any business, there's line item management, which needs to happen. Dollars and cents. What is it costing us? What's our return for the spend? Or is it a spend that we have to just make, like rent on the building or utilities?
Yeah.
But then there's everything else. Not everything can be line item management. And I think that's where those really gifted directors of nursing really shine. The ones that can pick up the finance, and not, I got to poke a little fun too. Little addition, subtraction. That's not too tough. We're not talking about milliliters. We're talking about dollars.
That's right. Just put a dollar sign in front of it. It's the same thing. It's the same math. It's the same algebra that they have to do.
Exactly. But then you can have those, I don't want to call them soft skills, but people skills, HR skills, building that culture, cultivating a team and that family. Because to your point, there's always somebody that will pay more. But are you willing to sell your soul potentially to the health system to make a little bit more money and then get ground to a pulp day in and day out? It's not always worth it.
Well, and you bring up an interesting point, too, is that I think what I've been seeing lately is people do chase the dollars and then often come back, or sometimes come back. I don't know if often is the right word there. But when they realize that it's not all about the bottom line, that the culture is just as important. I know we have to pay the bills, and I know that sometimes is challenging, but how long can you survive in an environment that you just, don't feel like getting up in the morning to go to work? And I think, and that brings up another important point, the importance of making sure you never burn your bridges behind you, both from the employee that's leaving or moving on to another position, as well as the organization that's letting them go. One thing that I've always said to, when we do training for our staff is that we have to be prepared to let people go and encourage them on their journey moving forward, because this is not, many of our organizations are very small. There's not a lot of upward mobility except into your position, as a director of nursing. So, when it's time for them to move on because they really want to do much more in an organization, there's no further positions in your organization, you shouldn't be discouraging them. You should be encouraging them. And because then you'll become known as that nurturing organization that is helping people, to succeed, regardless of whether it's going to be in that same organization. And I really am feel very strongly about that. And I think from the employee standpoint, you just never know what it's going to be like on the other side there, and how valuable, that experience you had, that you came from, was. And also, people retire and move on. So who knows? You might not have a position there now, but 5 years later, they might be looking for people that had been there before and that know that organization and would love to have you back.
Healthcare ends up being very much like the NFL. We're getting to the point of the year where we can start talking about preseason. I don't know if we have any NFL listeners in the audience or college football fans, but you don't really ever see head coaches leave the profession unless they retire. They're going to go be an offensive coordinator in LA now after leaving Buffalo. Healthcare is the same way. We see it on some of the automatic email responses that we get. So-and-so left, and then you see them pop up again at the center down the street. So that's such a great point, not to burn bridges, because you never know, and that's huge for culture. And I'm jumping around a little bit on you, John.
No, it's no problem. I do.
We're talking about compensation at the core here. Do you see a split in the age of those folks that are leaving for nominally higher compensation, or maybe even significantly higher compensation, and can gut it out for a period of time and then come back, maybe with their tail between their legs, maybe not, just going like, I didn't like it? I would imagine that as that type of position ages, money isn't everything.
Absolutely.
The older you get, the more clear that becomes.
Yeah, no, I definitely feel just even from our own company, we have a lot of retired, semi-retired, or people that are a little bit later in their careers who are coming into, work for Ambulatory Healthcare Strategies. And we I'm probably going to get in trouble. We don't pay as well as an administrator position does, but we have a very different lifestyle here. Everybody is remote. A lot of the work is. By the way, this isn't a way to try to recruit people. We're all right now, but it's a different lifestyle. One of our employees says, she still wakes up at 4:00 in the morning, but now it's going down to the to the office or to the kitchen where she can start working and not have to get into the car. Doesn't even have to get out of her pajamas if she doesn't want to. But and that's what I think we're seeing, is that a lot of those individuals that get up there, latter part of their careers, are looking for these types of positions where they might not be on the floor all the time, rushing to do, quick turnover. And we know that can be a challenge, especially as you're getting older, to, hoof it around the surgery center. Now, I don't want anybody to get the impression that you're not going to be hoofing it if you're a director of nursing or administrator, but, definitely there's a lot more time in that office and in front of a computer, than there is when you're on the floor. And I think, to your point, money is not often the issue there. By the way, and a good point I should make to those of you that are making major decisions in your organization, benefits are sometimes as important as, or more important, than salaries too. Especially as you get later in the years, when people start to realize that they need retirement, money, they need health insurance, et cetera. And those are things we need to spend time on. Looking at. We're looking to put together a human resource conference in probably early next year, where we're going to talk about more of these topics. I really don't know of anybody that has done a full day conference about human resources in the ASC industry, and I think it's time that we have that conversation and run the gamut. Talk about the legal aspects of it, the human resources management, paperwork. Nobody wants to talk about that, but we do have to talk about it, and benefits. 401k plans. How many administrators or director of nursing even know what goes on in that 401k plan? It happens to be one of those areas that I did know quite a bit about before I came into administration, but I spent most of my time explaining it to my colleagues and other surgery center administrators, so that they had that knowledge too. But it's very rare to have that type of background going into it.
Yeah, and the longer I'm in my career, the more apparent it becomes that HR is generally, if not the most important aspect of a business, it's top 2, top 3. Without people, businesses don't operate. ASCs are businesses, as you well know, but reminder for those in the audience, they don't exist without the people there.
That's absolutely right.
And that's all, we're still talking about the culture of an ASC, in essence. One of the other really important pillars of this culture to operate as a successful ASC is around physician engagement. And you had a couple key thoughts on that before we started to record, that can be a challenge, whether it's due to education, whether that's recalcitrance and following through on a plan, whatever it may be. But to take it from the top, I think it starts with physicians and physician owners needing to understand what an ASC actually is.
Yeah, we do. We never put ourselves out there as an organization that does startups, but it's amazing how many we have going on at any given time. And often what we're finding is that we're dealing with physicians who got the great idea to build a surgery center, or might have had an office-based surgery center practice, and talk to some consultant out there, or worse yet, one of their friends on a cruise ship, told them that they made billions and billions of dollars, running a surgery center, and they go out and do this, and they don't do a good feasibility study beforehand, or more importantly, it's not even the feasibility study. They don't understand the regulatory requirements that are behind running a surgery center. So we're rarely brought in at the very beginning stage. A company like ours usually brought in sometimes after the building has been completed or is almost constructed, and then we spend 3 to 4 months explaining all of the things that need to be done. You and I talked about this before we started recording, that helping a doctor to understand that a surgery center is really a hospital without all that additional infrastructure out there. But the regulations, and this is important for people to understand, the regulations around surgery are more complex in an ASC environment than they are in the hospital area. And the reason for that is because in the very beginning, in the the 80s and actually 70s, 80s, and 90s, regulatory authorities were concerned that people would shortcut the system to be able to provide those services. So they put a lot of regulations in place in order to avoid that. So individuals that are building surgery centers, physicians that are building surgery centers, have to understand that they're going to be spending a lot more time on governance, dealing with the regulations, making sure that they're hiring the right people in those positions. Get back to what we were just talking about, putting the right people in positions. Otherwise, they're going to be having regulatory issues all the time. We know that at least every 3 years you're going to have a CMS survey in some form. If you're accredited, you're going to have an accreditation survey, and if you're unlucky enough to be in some of those states like Pennsylvania that have annual state surveys, also, there's a lot of oversight going on, and you got to be prepared for that. And since I know none of the doctors, none of the owners really want to be dealing with all of that, documentation of the meetings, pulling together all the resources you need in order to pull off a good quality improvement program, emergency plan, safety program, et cetera, infection control plan. I can't spout them all off the top of my head right now, but all of those programs have to be put in place, as well as a very robust education program, not only for the staff that are in your organization, but for your leadership and for the owners. One of the things that we've tried with the podcast is to actually provide a short governing body version of our podcast. We've only, I think, had a couple over the last 4 or 5 years, but we do hope to ramp that up. We know that they don't have a lot of time to listen to that sort of thing, but what I would encourage organizations to do is to have at least one board meeting a year where you spend a good 15-20 minutes going through the regulations. Have a nice PowerPoint, administrators and DONs out there. Have a nice PowerPoint, or do a nice video, or let them listen to one of our podcasts where we talk about governance issues. But make it short. One thing I've never been accused of is being short with anything, so I try my best. But there is a lot of regulations, and of course, failure to follow those regulations could end up being catastrophically expensive. Losing your accreditation, your certification, or your state licensure could be very, expensive to get back, as well as the loss of revenue from not being able to bill and do those procedures. Or even having a survey that doesn't cause you to lose your license, but causes you to have like condition level citations or high level citations, is going to require another survey, and the cost that's associated with that. So being on top of that, making sure that you're hiring staff that are always on top of those issues is extremely important. The toughest decisions you're going to make as a governing body is who's going to be your administrator, who's going to be your director of nursing, and of course, who's going to be your medical director.
I think you're answering my kind of follow-up question here, is that ASCs are a different breed of cat, because you've got either a management company owning the majority of it, or you have physicians that have invested their money into building the center. They want to treat patients. This paperwork, I'm a physician, I'm the surgeon. What do I need to do all this for? But they do need to do that. So is there a way around getting significant physician buy-in, or is this just the way that it has to be? Can you hire around it?
That's a really good question, and one I've put a lot of thought into over the years. I think, there's no way to avoid the responsibilities that the governing body has, but you need to have a champion. And this is what I say to my administrators and DONs. You got to find somebody. Hopefully, one of the members of your governing body, one of the owners, is going to be passionate, about quality. Now, and I don't mean to infer that doctors are not passionate about quality.
No.
But many governing body members really think that quality improvement, risk management, emergency preparedness, infection control is all about the paperwork, and it's not at all. It's creating an environment that makes all that paperwork easy to deal with. You've got to really have a good culture out there. You've got to believe that it's important to document anything that doesn't go quite right. I mean, one of the challenges I always have with doctors is they never want anything to be written up as an incident report. And a comment that I make to them, especially when I'm a surveyor on survey, is that, as a surveyor, I'm not going to penalize you for writing up an incident that occurred, even if it involved, patient harm to some degree. But I am going to write you up if you don't do any incidents reports, and I'm certainly going to write you up if you had a situation that you didn't resolve as a result of an incident that occurred. You want to learn from everything. That's what quality improvement is about. Is you want to learn from everything that happens, and that's why you want to. When I was an administrator for 17 years. When I was an administrator, I encouraged people to write up every single thing. Now, it came back to me, I'd have 50, 60 incident reports, say, a year, which I had no way of being able to, go through all the time. But I much rather, look at an incident report and say, that's not really an incident, just because the coffee machine didn't work yesterday. I think I can let that one go. But, those other situations where, patient harm occurred or we had a near miss, those are the things I want to learn from. And often I have these aha moments with these doctors. If I can identify a situation that really benefited them, no doctor wants to ever be in a situation where they almost do an operation on the wrong limb. So those are often that's where passionate doctors, that's where your champions, suddenly show up. We had a situation many, many years ago where a doctor was doing a pain management procedure. And at the end of the procedure, he turns around and says, Ms. Smith, everything's all fine. And then, the patient turns around. She was on her front, and he says, "Oh, you're not Mrs. Smith, you're Mrs. Jones." And I'll tell you, and he had not done a proper timeout. The nurses in the room were culpable also because they didn't insist that they do a proper timeout. And the funny thing, well, not funny, but what came out of that is this became the champion. He never wanted that to happen again. He was totally all right with the investigation, with the root cause analysis. And so we caught him, months later where he would be, sneaking into a room before a procedure and telling the doctor, "Now, did you do a good time out there?" And he became our champion. I hope that that's not the way we get champions all the time. I hope people hearing a story like I just gave, gets those champions out there. But the rule number one, to your point, is that you've got to get them to understand that this is not paperwork. This is something and it's not just something that's required from a regulatory standpoint. When I got into the industry, there wasn't a lot of competition. I think the first surgery center I built, we were one of 2 surgery centers in the community. I can't even count how many are in our community now. But 2 surgery centers in the community. I was practically best friends with the administrator of the other surgery center in town. We did not compete with each other. We had lunch on a regular basis. We, collaborated on things. We were very careful making sure we didn't do, things like talk about how much we were being reimbursed. But we collaborated on a lot. That's not the environment that we have today, which means that we have to compete not only on price and getting the best employees, but also quality. And we want to be able to demonstrate to people that our organization is a high quality organization. People, patients are treated like gold when they come in, and that's how we differentiate. And the trick to that, the bottom line comes down to being able to provide good patient care, even more so than price, to be honest with you. Many times those decisions are not made based upon price when it comes to healthcare. They're looking for a place that's got a good reputation. It doesn't have a history of, bad outcomes. That's not in the newspaper. And to do that, the only way to improve quality is to make sure that you're identifying every situation in which you didn't quite reach that level of quality that you wanted.
Yeah, this is a little bit tongue in cheek, but as a patient making a decision where you need an outpatient procedure, this is maybe just me, but is the parking lot easy to park in, or do I need to pay for parking? Is the building clean? Is this physician well known with a good reputation? And then price obviously is a factor at some point, but very rarely would that be top of the list unless you're just in dire straits, which I do understand.
No, that's so true. I'll tell you, parking could be a deal killer. I'm going to the city tomorrow, and one of our centers is located in an area where I'm probably going to have to walk a half a mile to get to the center from the nearest parking lot. That is not convenient. Now, I have to have a very different attitude when I'm in an urban center, without a lot of parking right in the surgery center. But it is definitely something that people think about, and even being able to ease of getting people in. My mother, is older now, and whenever we're going somewhere, doctor's offices, we ask questions about how easy is it going to be to get her out of the car into the center,
Yeah.
especially if it's snowing or if it's raining or anything like that. And those are things we need to think about also as part of quality.
Yeah, very, very much so. Very much so. And with all this talk about quality, depending on who you ask, and we're leading into the big digital question here, John, depending on who you ask, having a digitized facility with a great practice management system and the matching EHR, some would have you believe that that will make all of this tracking and trending easier. And I think to an extent that they're right, but being withheld from meaningful use and no real reason to go buy an expensive EHR. The number one, the surgeon's already on their third or fourth or fifth or greater at their clinic. They don't like using it. Medicare's telling them you need to use it or else. And then you're at the facility, at the surgery center, thinking, if I don't need one, why would I buy one? Is that the prime resistance to these EHRs and ASCs, or what do you think's going on?
Well, I think some of it is old people like me. I'll be honest with you. If I'm a surveyor, I want a paper record because I can go through that paper record in no time flat. I'll go back and forth in the record, and I'll be, but of course I'm not the one creating it. So I'm speaking as a surveyor who wants to be able to get that through that record quickly. And trust me, when we're going through an electronic medical record, it is not a quick thing. So and I'm not alone. I get it. There's a lot of administrators out there and DONs out there who aren't necessarily creating the records, but they're the ones that are reviewing them and making sure they're ready for a survey to look at them. So there's a little bit of resistance there. I think the physicians are not usually the people that are resistant to the system until they see the price tag. And the problem, as you well know, in the industry, in the ASC industry, we're not as big as hospitals. We're not as big as the physician practices, and there's not a lot of options. There's really two major systems out there, two major companies that are producing the vast majority of those systems, and they're all they're great systems, but they don't. Neither of them will make everybody totally happy out there. And I hate to say that, but that's the reality, is that we have to make compromises because there just isn't a lot of competition for really high end EMR systems at the present time, and probably won't be in the future because of the size of our market.
Yeah, I think you're right about that. And just to go back to not being able to make everybody happy, if you look at the best in class scores, and for those not familiar, that's class with a K, KLAS. They're sort of the Yelp of medical software. For the last 10 years, the winning scores have been like a B minus.
Yeah.
The very best software out there is getting by with a B minus. There's a lot of room to improve. And having come from the clinic side of the EHR world for most of my career, on the clinic side, you had vendors just begging for mercy. Hey, we're trying to keep up with meaningful use 1, now meaningful use 2, and now they're switching us to macro MIPS, and we have to make all these changes to our product that you actually don't get to see and feel and touch except for the reporting dashboard. But my gosh, this is tons of development time.
Yeah.
And now they're just starting to be able to work through their backlog of functionality improvements, feature requests that are finally being handled since we're kind of steady state in terms of Medicare reporting. The ASC doesn't have that. They didn't have that meaningful use pressure to have certified systems.
Yeah.
So I kind of scratch my head and love our friends at these vendors. You know who you are, dear friends in the space. But that the systems aren't more well regarded comes as a little bit of a surprise to me.
Yeah, very well said. And I, to your point, I mean, now I kind of gave I don't want anybody to get the impression at all that I'm against EMR systems. It's quite the opposite. Because as a quality guy, as somebody that wants lots of quality data, it's hard to extract that data from a paper record. It's really impossible without spending the resources to get somebody to manually pull that information off. And that's the beauty of these newer systems. Even the ones that aren't that great, hopefully have some way to be able to pull data together from a quality standpoint and help you understand your cancellations, why things are canceled, the average length of time in the operating room, why you have complications, what types of complications you have, how the discharge works, the time from patients entering the facility to when they get into the operating room, to when they get to the discharge area, to when they actually get out the door. All of that data is extremely meaningful in improving quality. It helps us to understand what's happening, and we can take that data and start to make marginal changes And at each incremental step that we are making based upon the data, we can constantly go back and double check that data, make sure those changes are occurring without getting additional resources to it is so valuable. But I got to tell you, more importantly, I don't know if I should say more importantly, just as important out there is our other stakeholders want this data. The government wants this data. They want to know that you're providing good quality care. And how do you do that, without solid data that's coming out of your EMR systems? And payers care about this. But an up and coming area is employers. We as employers, you and I are both employers. We want to make sure that our employees are getting the best bang for their dollar. And of course, I can't, as I'm a small guy, I'd like not very big business, but those big employers out there, they can make or break a business. And if you don't have the data, they're not even going to look at you. So the time is coming. Even though there is no deadline right now, there's no requirement that at least I'm aware of, and there might be in some states, but certainly not nationally, to move toward an EMR system. The clock is ticking, and we're going to have to do that as we are required to have more data, as employers are asking for more information, as accrediting organizations, CMS, your states are looking for those quality improvement programs that you all have to be more robust and data oriented. When I do a survey of an organization, one of the weaknesses I sometimes see is that they're not gathering relevant data. I might go into an eye surgery center, not even gathering data on unplanned anterior vitrectomies. Well, it's the most basic thing that you do. How can you even, ignore that? Or they're not really properly gathering information from the infection control plan to determine how well you're doing in that area. And we learned some lessons from COVID, of course, that I keep telling myself, let's not talk about COVID anymore. Let's talk about, emerging infectious diseases. But we learned so much from that experience. It used to be that we would say, well, I'm not going to worry about, communicable diseases because I'm just not going to allow anybody in my center that has a communicable disease. Well, that was a big lesson from COVID, is that sometimes you're not going to know. And in fact, I would say often you're not going to know. And there's no reason to believe that trend's not going to continue. So now we've had to revise our quality improvement, our infection control programs to be able to track that type of information, to be prepared, to do, some, monitoring to be able to make sure that you're being able to handle that situation should it occur again.
And I want to go on record as well that both as a patient and as a member of the ASC sort of vendor community, I'm very much pro EHR. So that was a little bit of a dig earlier on. But to your point about being a surveyor, and this is true for the facility, this is true for payers, this is true for management companies that operate these facilities. It's way easier to extract data out of one chart on paper. There's no dispute about that. But what about at scale? What if I want to see everything for this quarter, for this year, for 10 years? You can't do that without software. It's an impossibility.
That's absolutely true. Yeah.
And this is just conjecture, but I think it's meaningful for this discourse that as you are seeing like these cardiologic procedures come off the IPO and are being allowed in the ASC, I think you got your head in your sand if you don't think something is coming. In terms of some sort of electronic requirement, that I'm not hoping for that. I'm not necessarily guaranteeing that, but you have to think about the mechanisms in play here where you have the only win-win-win in healthcare, which is the ASC venue for care, as much as it can be. And you don't think that Medicare wants to sink its teeth into that data and figure out why this exactly is, I just think you're fooling yourself.
Totally agree, and it's certainly from from surveyor standpoint. Now again, I work with HHC. We just had a major upgrade to our accreditation software. Wonderful upgrade, by the way. I do want to go on record of, because unfortunately I haven't always been happy about the change that's involved, because change is tough for especially old people or people that have been a surveyor for a long period of time. But the new system is wonderful. But it made me realize how important it is to have electronic. I can see in the future that we're going to be having our systems interface with your systems, your EMR systems, so we can be much more efficient with our our surveys, and that's the next generation. We're nowhere near that right now. So for now, I'm talking to a very limited audience out there, but for those people that are creating these EMRs, recognize the importance of having good interface. I know your company, for example, you've been developing relationships. That's one of the reasons you and I have been talking, is that I love the concept of that the ability to work together, software to be able to work together, and we have to do that. But as for those software developers out there that are creating these EMRs, please recognize all of the stakeholders. It's not just the people that are in the operating room. It's going to be the lawyers who are defending, the surgery centers. I do expert witness stuff, and oh man, trying to understand or look at these electronic medical records, from an expert witness standpoint, it is a nightmare. And as a surveyor, why should it take me so long in front of a computer screen, 2 to 3 times as long to be able to go through an EMR based medical record than I do on paper? We have to find ways to be able to make those interfaces more understanding to the people that are using it. I think there needs to be different interfaces. For a surveyor, you could easily, everybody knows what a surveyor is looking for. Maybe have that interface there. When you're doing peer review, getting back to the physician's responsibility in an organization, none of the physicians, I know I'm talking to some out there. I get it. You don't want to do peer review. It's a lot of paperwork. Well, I want to take that paperwork away from you. I want to focus you on the screen to the issues that have been brought up. Forget about the fact that it's on a piece of paper. Look at what's occurring on the screen there and be able to help identify whether that was good quality care or whether there's some room for improvement there. I'm not an expert on computers, but I know that that's the beauty of that, is that you can create interfaces that will make it easier for each of the different stakeholders of that EMR information to be able to interact with it in a timely way, to be able to gather information that they want to that they need to work with and they want to work with, and to be able to make positive changes.
I'll only add to that, to all of our EHR friends in the surgery center space and the practice space and the inpatient space. It's high time to move towards an API. Let's get out of the 80s with HL7, please. That will make everything John just described way easier. But one thing that is going through a rapid advancement, rapid adoption, more interest than anything I've ever seen technologically in healthcare is AI, artificial intelligence, or so-called artificial intelligence. Listeners of the show will know I'm a little bit of a skeptic in the terminology, but the software solutions are very real, some of them, and it appears to be here to stay. So, John, AI in healthcare, your thoughts? What are you seeing?
Well, I find it fascinating. We have been early adopters of AI. It helps us when we're doing our research to be able to gather information. It's another way of gathering information. Our job is tough. Try to gather, all the regulatory requirements, from the different states, from the different accrediting organizations, from OSHA, from CMS, from I could go on for a couple hours here. And AI is helping to gather that information in a much more usable format. I mean, we still have to go to the original source, but AI can be very helpful. So those are, if you are not familiar with AI or haven't even, experimented with it yet, definitely start working on it. Please, however, don't send me emails that have been generated by AI. I'm getting... especially, or if you're going to do that, at least take the headers off that indicate that you're, created it from AI. But I'm seeing more and more of that. By the way, I taught a class. I still am teaching. And the best final reports that I've ever had were generated this year by my classes. And I suspect that many of them had a lot of assistance by AI to create it. And our software wasn't able to determine that where the original source was for a lot of that. So as an educator, I'm frustrated by it. But I definitely see some radical changes occurring. When we were at ASCA 2024 this year, we had a number of speakers talking about some of the real benefits of AI, especially in billing. Imagine a scenario where you have artificial intelligence having a huge database of what it takes in order to code and bill a case for a given insurance company, given past rejection. In other words, they have all this history of past rejections, what how the coding was done, et cetera, so that, and that's integrated into your coding and billing system to be able to get that claim out there right the first time around. And that blew my mind right there. That blew my mind and I'm being told that is already starting to occur out there. Now, unfortunately, I used to teach coding, you know, um, in, at college level coding. I can't do that anymore because it's gotten way beyond my capabilities. But I have a lot of dear friends who are in the coding area and the billing area, and I do think that in the future we're going to find AI, making major inroads into that area. And I don't think it's going to be slow. I think it's going to be happening very rapidly. So you have to be prepared to adapt to it, adopt it as much as you can. Be wary of it, because data in, garbage in, garbage out is so true in all of our computer systems out there. But I do think it's going to have a dramatic impact on our industry. Even simple things like, we use it sometimes to help us write policies, or I should say rewrite policies, not so much to change the content, but to make it more readable, to
Yep.
people. I think many of us are, we're way too technical. And, I've learned how to be able to say, write this at sixth grade level, not because I think you guys can only read it at sixth grade level, but it makes it more understandable to everybody else. And particularly when we're creating forms for our patients, or if we're trying to create forms in different languages, AI can be a huge benefit to that. So I think I've already seen the advantages. I'm amazed. Isn't it true? I don't think we were really talking about AI last year. I think a lot of the AI conversations started in January of this year, if I remember right.
Yeah, you're all over it. The very bleeding edge was Q3 and Q4 of last year, but it wasn't really being discussed for healthcare. And
Right.
the only thing I'd add to your statements there is that for those shaking in their boots that AI is going to take my job, AI is going to replace me. For the most part, no, it won't. But you need to you need to have a little bit of your own agency. That what John you just mentioned, rewrite this at a sixth grade level. That's
Yep.
prompt engineering to be able to wield these AI tools to give you the outcome that you desire. That's going to be the have and have nots.
Yep.
Can you sort of put into place these prompts? I guess that's the only way I know how to say it is the prompt engineering aspect of it.
Yeah. I can see in my future doing courses on how to use AI effectively. Because to your point, I've had to learn a lot about just writing those prompts out, being able to, engineer them in a proper way. And that's really the whole secret to getting good information out of the system. So it used to be we had to figure out how to put a good Google search in there. Now
Yeah,
it's a very different approach.
that's a challenge. I know we're coming up on our time here, but there'll be some exciting news on the DocBuddy front there. But the real key in developing these AI based products is, can you make it usable for a very non technical
Yeah.
user that doesn't care about prompts? Maybe they're a physician that couldn't care less about the prompts. Just make it do what I want it to do, and then give that tunability and scalability to those that are into it and that do understand the prompt engineering to give them exactly what they want. But to be able to do that in both cases. So more to come there. It's what they call a teaser in the business, John.
Well, I'm certainly interested.
And as we wrap up our show, John, where can listeners connect with you online? Where can they find out more about what you're doing?
Absolutely. So we have a couple websites. If you're interested in the podcast, it's available just like yours on all major podcast channels. Ours is only audio, so who wants to look at this face all the time? Sorry. So our podcasts are audio, and if you can't load it on your cell phone, you can always go to ascpodcast.com. We also have a website called ASC Central, and that's asc-central.com. That's where all of our educational programs are located, including our very well-known, and we have over 300 graduates from our boot camps over the last 4 years. So definitely you can look that up. And of course, if you really need a lot of help and need to have ongoing assistance, Ambulatory Healthcare Strategies is always there for you, and that's at ah-strategies.com. You can always email me at jgailey at. I know you'll give that information out, so I'll let them figure it out from your show notes. But feel free to email me. I'd love to talk to you.
John, I'll save you the spelling. Of course, all of those links will be provided in the show notes and the show description. And on behalf of the entire Doc Buddy team, John, I want to thank you for joining us. And to our audience, thank you for listening. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube so you always get our newest episodes. And until next time, I'm your host, Eric. We'll talk soon.